You've been gaslit into believing that you need meds, injections, and surgery for your chronic pain. We are your whistleblowing shrinks, Dr. Tara Lynn and therapist Jen, and you are listening to the Gaslit Truth Podcast. Welcome aboard, everyone. Today we have a special guest. I've been waiting a while for this one, actually. We've been trying to sort this one out for a few months now. So, Dr. Clayton Dir. Clayton Dir is a physical therapist, a doctor of physical therapist. That's important to point out. He is a performance physical therapist who specializes in performance. He has worked with national and world champion athletes in powerlifting, strongman, CrossFit, and many other sports. That's really cool. He also has a focus in chronic pain and patients who have been dismissed by the medical system or gaslit and being told they are fine. He is the host of the podcast Heal Without Harm, where he discusses the pitfalls of the medical system and bringing on guests who are actively building a better system. Welcome to the show, Dr. Clayton.
Thank you so much, both of you, for having me. I've been following your content for quite some time, and I'm catching myself watching, being like, "Hell yeah, yeah!" and like agreeing with that. So I feel like we similar paths, different genres, maybe.
For sure. I think there are so many different specialties that Jen and I are running into that are thinking very similarly now. So it's really cool when they kind of cross and meet together. So excited to have this conversation, particularly about chronic pain, because I don't think we've had that before. Have we, Jen? I don't think we've talked about chronic pain.
Nope.
No.
It's a new one.
Yes, it's a new one. And I know that a lot of our clients have a lot of chronic pain and they've been through the ringer in pain clinics and things like that. So I'm really stoked to listen to what you have to say about this, Clayton.
For sure. No, and I'm excited to learn a little bit from y'all, because there's sometimes where patients will come in and I can tell that it's almost like a sensory processing disorder of some sort, or at least that's playing into it, where like the tissue's doing fine, but you're still feeling pain. And I know I can help, but I know I'm not going to be like the root cause fixer. And so trying to find someone to put them in front of to finish that out or assist in that care is something that I'm still actively looking for.
That's intriguing.
That is
I
really
love
intriguing.
that. Yes.
Yeah.
So the tissues themselves heal, and you can see that, and yet there is still this viewpoint that they take of pain, and there is still a subjective statement that there's still pain levels there.
Have you guys learned about the homunculus of the brain? Does that sound familiar?
Did you
say monkey?
Homunculus. Very, very similar. There's a couple of shared letters in there.
You don't have to validate. Thank you. That's cute. Oh, I like you. Is that quite Jen? You're an idiot. Stop it. All right.
The brain has a map of the body. And if you just type in homunculus, if you can figure out how to spell it into Google, you'll see that different parts of the brain perceive sensation from different parts of the body. The hands and the feet take up a huge amount of surface area in the brain because that's where we get most of our sensory from, right? If I drew the letter 4 on your back with like my fingernail, you may be able to recognize it. But if I drew it on your hand, you would know exactly what you're feeling. And so the brain has its own perception of the body. And so sometimes it gets like this learned, almost like a learned behavior. Like if you touch my arm, it's going to hurt. So please don't touch it. And then that tissue heals, but you still think if this arm gets touched, it's going to hurt. And so we have to work through that. But sometimes I'm not the best person for that because I don't know how to navigate it, or I don't have the same maybe information you guys have in your brain, or I don't know how to unfold it and have that conversation. But most of the time I just lean on exercise and weightlifting and be like, hey, we're just going to work through this, and kind of through that process, you'll get more comfortable.
Right. It reminds me a little bit of, it reminds me a little bit of how traumatic memories are stored in trauma storage, right? And how there may not be a threat and there is nothing there like in front of you, and yet we still perceive there to be that there for us.
Yep.
Mm-hmm.
For sure.
I have a lived experience, a recent one, because my front tooth cap just came out, right? And so I had to go to I know, right? Anyway, I had to go to the dentist, and she was working on it, and it was so sensitive, and she kept saying, this is weird because most people don't have this level of sensitivity, whatever. And I'm thinking, well, I do. But the thing is that she would get close to it and it felt like a jolt of lightning and she's like, I barely even touched your tooth. It was like this anticipatory, and I felt it. Like I felt that pain where it really wasn't even there. It was like this, and I kept saying to myself, this is anticipatory pain. This is anticipatory pain. Like, don't do it. Don't do it. So I feel like this is like a similar a concept in real world. Like you
It
kind
is.
of anticipate that pain happening.
Mm-hmm. It's along the same
Well, you
lines
got to get your monkey checked then, Terry. Get your monkey checked. This is
It's
seriously.
along the same lines on why amputees still have like phantom pain,
Yes.
because the brain still has the map of that limb,
Yes.
even though it's
Oh,
not there, type of thing. And so
Okay,
when you have
phantom limb
this
pain. I know that. I
incorrect
remember that
feedback.
from Psych 101. Okay, now you're talking my language here. Okay.
That's it. But I also want to say I used to work in a pain clinic some years ago, and in a mental health capacity, and there would be so many people that would come in, and that's where I learned the intersection between emotional pain and physical pain. When
Mhm.
you have physical pain heightened, you will have more emotional pain. When you have emotional pain heightened, you will have more physical pain. It's like this feedback loop system. And I feel like some of that was anticipatory pain or historic pain that you expect to happen again, or the belief that it will never be gone. So you have to live with it forever.
Yeah.
So, the head is connected to the body, essentially, is the moral of that.
Well, then you tell that patient like, "Oh, by the way, this tissue's fine. I don't know why you're still in pain."
Yes.
And then that's the end of the conversation,
Yes.
and then it's like, well, what am I supposed to do with this? And so I think even there was one gentleman actually who came in. This was within my first 6 months of getting out of school, when I felt like I still had no idea what I was doing. He came in with shoulder pain, and the story, I saw him in January, but he started having pain in, I think, October. He got the flu shot, and he's not saying that's what caused the pain, but that's when he started noticing it. At least it created some soreness. Never really went away. He got that, I believe, in October. November came around about Thanksgiving. He went to a doctor. The doctor said, "Oh, I think he went to two doctors. I don't remember which order he got the diagnoses in, but one of them said, I think you tore something a little bit. But otherwise you'll be fine. It'll heal," kind of thing. Somewhat like sent him off. Went a couple weeks, pain was still there / getting worse. Went to another doctor and they just said, "Oh, you have tendonitis," and kind of like dismissed him again. Not necessarily rudely, but like sent him on, was like, "Oh, you'll be okay." It was Christmas Eve. His dad passed away. And he remembers that between Christmas Eve and like New Year's Day, he was moving a ton of stuff out of his dad's house. And somebody goes, "Isn't your shoulder hurting? Like, you're moving these boxes without issue." He's like, "Oh my gosh, I totally forgot that I was having shoulder pain." And within a day, like it was like 10 times worse than it was. He came into my office. He was a classic like blue collar type dude. He lives on like a small farm. He's got, those side by side almost monster truck golf cart looking things. Like the dude is like very physically active. He was also a welder. Well, I saw him for 30 minutes, by the way, which is normally an hour eval. This was like a half-hour free consult to see if we're a good fit. And he was telling me the story, and he's like, "Yeah, I'm a welder, and sometimes I'll have to be in really weird positions. Like I'll be on up a ladder, leaned over here, arm, finagled through this like small hole to weld a piece of metal." He said, "I just don't know if I'm going to be able to keep doing my job. It hurts so bad to go to work." And I kept asking questions. And then I think the thing that really rested on his heart was he had a 4-year-old son. And he's like, "I want to be his baseball coach. I want to take him through, like baseball, blah, blah." He's like, "And I'm afraid that won't happen now." He's like, "My shoulder hurts so bad for the last 3 months. I just don't see this getting better." And so I tested a bunch of stuff, like everything I possibly could, and nothing recreated his pain. And I was like, "I don't know what's hurting you because you're passing all my tests. Range of motion is good. Strength is good. Mobility is good. Me palpating on your tissues is good. Like, I don't know what's going on right now, but come back later this week. Let's do a full eval and let's start treating the shoulder." 3 days later, he came in 0 pain. Like he had no pain left at all. And I said, "Okay, let's try to hurt you." Essentially, I was like, "Let's like do this strength test and like push it hard. Let's play catch with the ball, but let's make it a 4-pound ball. Like, let's push these things to the limits." Never saw him again after that. Never had pain again. And I was like, "What the heck was this?" Like physically did not touch him. Had a conversation with him. Essentially, like validated what he was feeling, saying like, "I know they say this, but all my tests are showing this. Let's go push your tissues to the limit and see what happens." And that unlocked, like you were talking about, the emotional side of things and the perspective or perception of pain, anticipation of pain, and then also getting like incorrectly validated potentially from other doctors. Like when you have an image that shows a tear, you're like, "Oh shit. Like, what do I do now? Like, what am I losing now? Am I going to lose my job? Am I going to lose my ability to play with my kids?" And then that like catastrophizes and goes from there. And so that was a really cool turning point. Thankfully, within my first year of practice, that really opened my eyes.
So, okay. So does this lead, as we jump right into this then, does this lead into the statement that you had made to us that surgery should never, most of the time, be the first option?
Unless it's like, if we don't do this in the next hour, you're going to lose the ability to walk type of stuff, or like
Okay.
dramatic, car accidents and stuff. Yes. The
Okay.
people who like they don't really remember when their shoulder pain came on, or like the knee just started bothering them. They started running 6 months ago, and about 3 months in, my knee started bothering me a little bit. Those are the people that end up oftentimes showing up in an ortho office and getting a surgery, or they have back pain and they end up getting a surgery. Those are the people that I'm speaking to now.
Yeah.
Where surgery is often, it's this classic algorithm, right? I go to the doctor, they take an x-ray, they don't find anything. They prescribe opioids and muscle relaxers. That doesn't work. They say, okay, let's get you signed up for an injection. They get the injection. I would say it seems like 10 to 15% of the people that come into my office, so a biased sample, but that come into my office and get an injection, they report, wow, this hurt so bad. I felt tingles down my leg. Like this made everything worse. Like those are the reports that I get more often than rare, probably just more in the uncommon category. But if that doesn't work, then they say, all right, let's sign you up for an ortho consult. And I think the ortho consult should be like, let's investigate this and see what's going on from an orthopedic standpoint. Unfortunately, it's more of, here's what your MRI shows. When do you want to have surgery? And it's almost like no in between.
No, they go straight to surgery. Like it's like you're consulting for surgery at that point.
Exactly. And a lot of times PT is not recommended. I think it's becoming more recommended, thankfully, kind of, because insurance is actually somewhat requiring it. However, the way it is sold is the doctor goes, I mean, you can try PT for 6 weeks, or you need to try it first.
Yes.
But then go ahead and sign up. And it's just like, cool, thanks, bro.
Well, and I just went through this with my knee, and it was one of those things where I woke up and there it is. Like I don't have some great, awesome thing that happened where I was like CrossFitting and blew my left knee out when I was, doing some, that was none of that good shit. Right. So what's interesting too, is there's this, insurance, and you talk a lot about insurance too. So we dive right into this, why insurance does not have your back in this case, right? You shared this with us, right? Like, and you can tell us more about why you say that. But even when it comes to PT, there's limitations on it.
Yeah.
You get, here is the parameters of how long you get PT, and then that's it. And so I often question that too, where you get your 6 sessions of PT and you're done. And then patients are done. You're done. That's it.
And a lot of times they're no better, or they're just a little better. Right.
Right.
And what's frustrating, here's my thought that like goes into the conspiracy type of thing, but not even conspiracy, but it's like realistic at the same time.
This is very real. It is.
Who makes money from the insurance or from like big pharma? Who makes money off of PT? Like nobody. Like
not the physical therapist. That's
of course not. No, in the 90s they made more money. In the 1990s, a bachelor's degree in physical therapy got you more money per patient than in 2025, where I had to do a 7-year degree and drop over $100K.
Yes. So because physical therapists now, the majority of them are required to have a doctorate, correct?
All of them are. Yeah. Well, unless you had the bachelor's and were grandfathered in, or the master's, and
right. So that's kind of a newer-ish. I mean, I'm old, but
and
that's
I would
kind
say
of
I was even below normal. Like most people, I think the average, I can't remember the website, but there was a website that helped PTs pay off debt, but they helped everybody, but primarily PTs. And I think the average is 150 to 170 in regards of hundreds of thousands of dollars of debt for a PT. And then we come out and we make 60 to 80. Like my brother graduated.
I feel this.
Sounds like us. Yeah. That's same.
Yeah, they graduate from engineering school at 4 years and they're making 80K 2 years out of school. And I'm like,
right.
Yeah, I wish I would just be okay with sitting at a desk all day. That'd be nice. Not to dismiss them or discredit them, but like that's a way better.
No. Well, trust us. We understand. Yes, we totally understand that.
So
I want to circle back to the statement that you said. Sometimes it's the way that it's sold. That the way that the intervention is sold is very important. And I think about this as you were talking. I was like, yeah, PT is kind of like mental health, kind of like the red-haired stepchild of the medical model, if you will. Like, because we're often the last sold too, especially for pain patients. Well, you could go see a therapist. What do you think? It's all in my head. And then suddenly that patient doesn't want to see a therapist. They don't want that, and they're resisting pretty much everything because they've been sold this idea. And also the way other interventions are presented to them as being, well, you could try it, but right, kind of like physical therapy. Yeah.
Honestly, I'm a huge analogy and metaphor type person. It's the way my brain works, and I think it's the best way I can relate to people. And I was just listening to Simon Sinek a couple days ago, and I love the way he talks on a lot of stuff. And there was things that he was saying that resonated a lot with me. And he talked about how in 2020, like everything got blown up. His like business life was like going down. And he's like, yet I had the best time of my life. He's like, the amount of problems that I had to solve and the challenges that were faced in front of me, although it was a lot of negative, it was enjoyable. And I liked the flow state that I was in and all that. And I think that's how it is for me when it's like the more problems that show up from a high perspective on, our type of conversations, trying to change public perception and stuff like that. Or even just when someone comes in and I've had somebody sit in front of me and say, how many times do I have to come here before I get my MRI? And I'm
Oh,
like,
yes.
what do you think
Checking
the
off
MRI is going to give
boxes.
you? And what I enjoy about that though is like, okay, cool. The difficulty level in today's case is expert mode. This person thinks you are worthless and this is not going to be helpful at all. And I'm like, just sit back and like, I'm going to sell you on this. Now, some people are just not going to be sold, but I enjoy that challenge now where it used to intimidate the absolute hell out of me, where I will use their own reasoning to like get them to be back on my side. Like, what do you think the MRI is going to give you? Well, it's going to tell me what tissue is wrong. Okay. So do you believe that tissue is the reason you're in pain? Well, sure. That, it says my supraspinatus is slightly torn. Okay, let's test it. I've got 3 tests to test and see if that tendon is problematic or weak or painful. And then we'll go from there. And let's say it is positive. It's like, okay, what do you think surgery is going to give you? Well, they're going to fix it, right? Well, I'll tell you right now, because you can lift your arm, no, I don't think it's completely ruptured. And so you're going to get way better outcomes by going through PT and letting it heal. Do you want to be in a sling for the next 8 weeks? No. Can you do your job like that? No. Okay, cool. So stick with me. Let's save you time, money, risk of infection, risk of like any other like adverse effects of surgery. And let's get to this, and then we go one step further. And in that session, I will have a test that hurts or a test they can't do, right? A range of motion test, a strength test, something like that.
Mhm.
And then I will find the tissue that I think is wrong and I will dry needle it. Are you guys familiar at all with dry needling?
So I've never had dry needling. I've heard of it. If you want to
Yep.
explain that a little bit, I think that would be an appropriate thing to do.
For sure. I'll circle back to it after I
Sure.
finish this kind of like little storyline. So
Yep.
I will dry needle that muscle. And let's say it was 8 out of 10 pain once they got to like 90 degrees of lifting their arm. So they get up and they're pointing to the side and that hurts 8 out of 10 pain. We dry needle the muscles that I found to be problem and we retest and you see their face go up to 90 degrees in that anticipatory pain that you're talking about. And then you see this like, oh shit. Then they're like, who are you? I'm a magician. And they get like 160 degrees, like almost bicep to their ear. And they're like, this hurts like 3 out of 10. Like, what did you do? And it's like, oh, I got that muscle to essentially like calm down. I
Mhm.
changed your pain perception and then got you to move it. I removed the pain so that you can start getting the range of motion back. And like, do you think you still want to get surgery now? Significantly with like literally so let's get after this, and so
Mhm.
that's what I've really with initial eval. So going back to the dry needling, I love how many great inventions or findings are complete accidents. And so they actually found dry needling they were doing a study and they're doing trigger point injections. So injections on trigger points are like knots in the muscle. And they of course do like, I don't know, double blind or whatever. Some people get injected, some don't. Well, the people that got a needle but no injection got better. Because when you
Mm.
put a needle into a muscle that is in a trigger point or in a knot or in spasm, if we want to think of it this way, like imagine like 10% of these muscle fibers are stuck in cramping. They're just turned on, they can't turn off. That's where a lot of your pain is coming from and your dysfunction. And then we have to figure out why, but that dysfunction is stuck. If you just poke it with a needle, it disrupts that spasm. Usually it is temporary. You'll get 2 to 5 days of relief from the first session of dry needling. But when I poke that needle in there, you'll get this twitch and cramp like sensation, and then it'll relax. And you get what we call a therapeutic window, generally on the first sessions of about 2 to 5 days of less pain with movement, less pain when using that muscle, stretching it, strengthening it, whatever it may be. And that's what I tell them. I said, I can dry needle you every week, give you no other instructions, and I'll practically be a chiropractor who pops your back. You just keep coming back. I'll keep, But if you
Yeah.
want to solve this thing long term, take advantage of the time that I just gave you and go do the exercises I recommend to actually solve the problem in this muscle and make it not go back into spasm. That's how you stop seeing me. That's how you start doing your life again without pain. And so it gives them the power, but I'm helping them shortcut.
Huh.
I'm just enamored by this because I keep rolling through my brain on how many people dismiss PT. And
I know.
by the way, I've dismissed PT. I have.
Honestly, To give you some credit, I dismiss a lot of PTs when I'm the third one they saw and they're like, why is this so much different? And I'm like, what exercises were you doing? And they hand me a 1980s print off that's been photocopied 17 times. And it's like, stretch your calves, stretch your quads, stretch your hamstrings, stretch your hips, do the pigeon stretch. And I'm like, yeah, none of those are going to help you. And they're like, they don't. And I'm like, how long does it take you? 28 minutes. I'm like, I would quit too. And so I'm trying to decide, is it the orthos and surgeons giving us a bad name, or is it other physical therapists?
Ooh.
And a lot of the times I would say not a lot of times, but it seems like half the time it's PTs and corporate medicine, whether they want to be there or not, where they have to see 2 or 3 people an hour. And so then they just default to like, well, let me just show up, hand the piece of paper, tell them, yeah, it's probably that tissue, and then not actually solve problems.
And so it's not individualized is what you're saying. Like,
most
is there
is not, no.
There isn't. Yeah.
Sure. So our clinic is cash-based. We're out of network, and we see 5 to 8 people a day per client, like per provider. And my boss was the 6th person to join a mastermind in PTs like us, PTs that run clinics like this. There's now over 200 people in that mastermind. And they have a course where they walk people through a 3-month process on how to start a clinic like this and run it. They've now helped over 1,000 clinics throughout the nation. So it's coming, like things are happening, right? And so PTs are getting out of that like mill ran PT. It's coming around. And so then it's like on TikTok, one of the best ways I've found to help people is show them what I do, kind of like you guys talk about what you do. And then they're like, hey, can you help me? I'm like, I'm in Wichita. Where are you? Boston. Cool. Can't help you. And I actually went to this Facebook group of 6,000 providers. And I said, can you guys please fill in this Excel spreadsheet for me? And so I will go on there, find somebody in Boston. I will kind of like verify their website. And you can usually tell the difference between corporate medicine and like one of these guys. And I'll say, hey, check out, Move Better PT on North 4th Avenue, whatever. And they'll be like, great. And then a month later, I'll see in that Facebook group, whoever sent me somebody in Boston, they said they saw somebody on TikTok. Thanks for the referral. And that's been my attempt to try to get people to more PT and validating that, like, yeah, I would have quit the PT that you tried the last 3 times as well.
Which would be the more traditional, as you say it, right? Like the way that traditional PT can fail patients. Yeah. This is kind of what you're talking about.
Exactly. Yeah. They're not helping people, but it's because insurance still pays for it. Like insurance still reimburses if I put an ice pack on somebody's back, they'll give me $12.
Who shouldn't do this? Who can't do dried needling?
Good question.
What kinds of patients can't do that?
Yeah, there's not many contraindications. Pregnancy, if you're going to be doing any sort of dry needling around the area, like if you're dry needling their calf and stuff, you should be fine. I would say that we still join the whole, like, don't do anything to this lady in the first trimester because you never know what could happen.
Right.
But I just straight up don't dry needle anybody who's pregnant. And plus we've got now a pelvic floor specialist who takes on those gals. If these people have a suppressed immune system, autoimmune disorders, things like that, we're going to be very cautious, potentially just not do it at all. Needle phobic, they're scared of needles. I've got one gal actually coming in today that she still won't let me dry needle her. I'm like, I promise you it will make your hip better, but we don't like, I'm like gradual informed nudging type of
But I
thing.
don't want to make your PTSD worse at the same time.
Yeah, exactly. And then if there's active infection in the area, if they're on like blood thinners, we'll be a little bit more cautious. I mean, honestly, like from a medical perspective, just like any normal contraindication of poking a needle into their body are going to be the usual contraindications ultimately. But you can do some crazy stuff. Like we've dry needled like the orbicularis oculi, like the muscles around the eye for like ocular migraines and stuff. I've done temporalis before. I've not done this, but you can do TMJ. So like your masseter and then your pterygoids up under the jaw for those types of things. So people who grind their teeth or have like popping and clicking when they open their jaw, stuff like that. You can do the abdominal muscles. I'm not certified to do it because it takes a lot of training because, your abs are pretty thin. And then there's like, I don't know, all these special organs underneath. So you have to get certified in that, but you can dry needle pretty much any muscle.
Okay. And even for individuals who have had like major surgeries and there's been structural damage that's been done, you've had your hip replaced or your knee redone or
back surgery,
you slipped a disc and, your L4 is jacked up and 20 years ago you had to have that fixed. Okay.
I would say too, this is where it kind of goes back to the whole like parallel with like mental approaches and like PTSD and traumatic events. So needling, the way I usually talk about it and teach it is more trigger point style dry needling. So this muscle's in spasm, poke it, make it go out of spasm. There's many different approaches though too, where if you poke a needle into an area, the body's going to see that as injury and start the inflammatory process, which is appropriate, right?
Yep.
And so some people, you just need to poke the area, like lateral elbow pain. Sometimes some protocols say just put like 5 or 7 needles in there, let them sit for a couple minutes, and then pull them all out. And then it's going to like start this process that your body's going to go heal it up. Then there's also dry needling that they think more into the fascial system. And so if you just type in like dry needling scar on any social media, you'll see someone with like a knee scar on the front of their knee. And this will always have to be once it's closed up, and the general protocol is 12 weeks post-surgery.
Sure.
But they'll put the needles in and they'll wind them, is what they call it. They'll twist it. And it's kind of like pulling or like up some of that tissue to help that scar lay down even better and desensitize it and help the scar become nice and smooth instead of like super keloid and things like that. Now that's one that I don't do that much because I don't see those people in general. And then I've never really like put it into practice. I was taught, but I never put it into practice. So I don't have the reps for it. And then the last kind of option is homeostatic points. This is where it goes a little bit more voodoo-y kind of sounding. But anywhere there's a branch of nerves, and so like your sciatic nerve goes down the back of your leg, and behind the knee it splits. It goes into your tibial and fibular nerve. We would call that area kind of like a little plexus, right where it branches out. And there's points there where if you put the needle somewhat close to it, you just push it in and then leave it. It'll desensitize the person's nervous system and kind of bring it down, just so that they're a little bit less fight or flight in the area, a little bit less protective. So you can most of the time calm down the pain perception from there down or in that area.
I wonder what the intersection is between PT and mental health. Like I sit and I think like, how can mental health professionals partner with PT? Because I know that there can be like, oh, go to a chiropractor. Like that's like the only, thing that people talk about. But I've been thinking about this for quite a while, even before you came on the show. Like, what is the partnership between mental health care and PT?
I think it would be crucial. I think the hard part for me and putting it into practice is y'all are overran. Like if I want to get an appointment with y'all, it's like, cool, I'll see you in 9 months. At least that's the perspective. That's what's hard is like, you don't have like your people, it feels like don't have time to like set aside and like come talk to me. Just because there's so many people asking for the services that you offer, I've had a hard time communicating that way. And then the second thing is, even if I do have you sold and you're like, yeah, you need to go see Clayton for your knee pain, and I think this will help break through some of the stuff you've got going on psychologically, that's asking that patient to spend more time and money. And so then when you actually get to implementing it, the barrier seems like, gosh, I just got to go to all this therapy and I don't have the money to do all this. Is my other perception there. So I fully agree with you on paper, right? It's very, what's it called when you have a bunch of providers together, like working together?
Treatment team?
Kind of like that. There's
Holistic?
like, no,
I don't know.
it's more of a hospital type termed thing where it's like multidisciplinary I think it's interdisciplinary.
Interdisciplinary team.
Where you're getting all the different perspectives where, like I told you, my patients sometimes that I can tell there's a little bit of emotionalness wrapped up into this. I can help you the best I can, but there's somebody like y'all who probably have like this very strategic approach, and you're like, oh, we'll knock this out. We're going to do step 1, step 2, step 3. And I'm over here like, I'll give you a hug and tell you like, we got this, which helps, but it's not very.
Calm down. For sure. You want a hug?
Okay.
Calm down.
So can you do a quick PBS special on the difference between dry needling and acupuncture?
Yeah, for sure. The only thing that's similar is the needle. We buy the same needles and that's it. When it comes to acupuncture, I'll give you my understanding of it, but I don't have an education in it necessarily. To my understanding, most of the time acupuncture only goes into the dermis, which is like the same level of skin that like tattoos go to, right? Like you're puncturing the skin, getting a little bit in, and you're leaving it. They are going to follow more of the Chinese or Eastern medicine approach, where they're looking at the flow of energy, the flow of chi. They're going to look at your meridians, and they may be poking your ear to solve like your left hip problem. And it's been around for a long time, and a lot of people swear by it. So I'm sure there's some stuff to it. I just don't know what those studies look like. That's acupuncture. Dry needling, again, if I kind of keep in the window of that trigger point method and treating that way, we are putting the needle all the way into the muscle, and we're trying to find the dysfunctional tissue ultimately. I don't put all of my like stock in, is this tender to touch? I don't put it all in the stock of, is this muscle dysfunctional? Like when you try to use it, I use 3 or 4 different things to kind of like cluster together. So for example, if we use that rotator cuff, the supraspinatus one, someone who comes in with shoulder pain, they can't lift overhead, anything over like 90 degrees of arm lifting hurts. If they put their elbow at the side and they try to like open up their arm, which is called external rotation, if that hurts, that's starting to tell me like, okay, rotator cuff's probably involved. And then I go palpate those tissues and I say, is this tender? Is this tender? And they're like, yeah, you're pushing really hard. And then I like push their shoulder and they're like, oh, wow, that's way different. The right one makes me want to punch you. The one that's not hurt feels fine. And usually I can feel like a tender top band of tissue. So you're rubbing over this muscle and there's like, wow, did you install a metal cable into this thing? Like that's where we need to go.
Okay.
And so that's when I'll take the needle and I'll tap it in, and I'll usually do what's called pistoning, which is where we kind of go in and out in different directions. We're trying to treat a large surface area without actually pulling the needle back out of the skin. Usually what I'll feel is I will see and or feel that muscle twitch, and it's super cool looking. If you just type in like dry needling twitch, you'll see it on social media. Super satisfying. And you will actually have the patient say, wow, that's recreating my pain. Like I know you're poking me in the back of the shoulder blade, but I feel it in the front of my shoulder. I'm like, cool, we're on the right path. This is what we're looking for.
Hurts
And
so
you go,
good.
you take it out and you
Yeah.
retest.
Hurts
Usually
so
the whole process
good.
takes 5 minutes or less.
I'm just, it's so hard to not personalize everything that you're saying right now, whether it's for like myself and like shit that I need to like explore,
Yeah.
right? Or for people that I that I love. As when you came on, before we started, I was telling you that I was just in a pain clinic with somebody very close to me, and that person has had a couple major surgeries, 2 on a knee, and then 1 with a slipped disc that happened many, many, many years ago. So there's this chronic back pain that exists as well. And I went with them because they wanted a holistic perspective on pain management.
They also need an
And
advocate a lot of the times with them.
Yes, an advocate.
yeah, and so that's all I was, right? And so I went along, and of course I had a visceral reaction going into the pain clinic because of all the like damage that has happened in my traumas from like just white coats in my life, which that's a new thing for me. Side story on that. Anyways, and I'm sitting there and listening, and the individual said to this person that I love so much, "This is chronic. It will never heal. It will never get better." And sat there listening, and I'm like, yes, I know there are structural injuries that exist here. We've had 2 surgeries on knee in the last year and a half. We had a major back surgery many, many, many years ago, 20 years ago, right? That exists there. You've been managed on opiates for over 20 years. That's the treatment intervention, right? Is the opiates. And I'm sitting here
A great
listening
money
to
maker,
this.
by the way.
Yeah.
What?
So which is a great money maker.
Great
Right.
money
Oh,
maker,
I'm
yeah.
sitting here like I kept telling this person so much that I love. I have to be so careful not to say who it is, right? Because he'd be so pissed at me. I'm like revolving door, forever consumer, right? I'm sitting here like saying all these things. And I'm just listening, and the verbiage that's given is this will forever be. This is degenerative. This will not get better. We can do all these interventions that are going to kind of make it a little bit, like make your pain a little less.
Yeah.
But this is for your forever sentence. Death sentence. And I'm just sitting here and I'm like, fuck this. Like from what perspective? Oh, I know from what perspective this comes from. A very narrow-minded money-making Western medicine perspective. Would you say that to somebody? And I'm listening to you here talk about these options, which dry needling was not an option given. The holistic options, there were some given. So I was like, okay, that's great. And one of them was acupuncture. But that statement to patients, this won't get better. It's degenerative. You will have this forever.
Well, I want to say hope is also an option.
It's just like gone, right? And I just turned me off so much. And so I don't know what your thoughts are on that, but there's this verbiage that we say, and that's pain clinic. This is a pain clinic doc, right?
Well, I mean, like you don't go to McDonald's expecting to get sushi, right? Like
What
else would you expect from a place like that? I'm not saying that to you, but like,
no, you're right.
No,
we all know.
you're right. Keep going with the analogy. You're on.
And I think that's why it's important that I just shared a post yesterday. I don't even know who it was from. It said, we need more doctors on social media. And it talked about, because there's not only bad information on socials, but when you actually go into the medical world, that's what you get. Like every single time. Like you can, where are you guys located at? Like where was this experience at? What state?
I'm in Wisconsin. It was here in Wisconsin.
Yeah, I'm in Kansas, and we have the exact same thing. Like, you know what I mean? It's so predictable. And exactly what you're going to get. And so, what else kills me too, when you talk about hope and stuff, I just shared a post and it got a little bit more traction than I had anticipated. Nothing bonkers, but I said, like, here's the advice I would give as 5 years in practice if I wasn't afraid of hurting your feelings. And then the caption said, the pain may not be your fault, but it's your responsibility.
Yeah.
And you're the only one that can change it. And change requires change.
Yes.
Yeah.
The medical system does such a good job of saying it's not your fault. Poor you. You're stuck like this. It's just going to happen. And it's like, no, like come into my clinic. Let me look at things and let me assess you. And then let me show you what you can do. Like one of my favorite things to do is as you make someone's pain go down, walk out into the gym and say, have you ever deadlifted before? And they're like, no, doesn't that hurt your back? I'm like, well, let's see what happens. And I hand them a kettlebell and say, pick this
you
up.
You got him deadlifting 400 pounds.
And I say, pick this up and set it down. They pick it up and they'll have 50% good form, let's say. They set it down and I say, how much weight do you think that is? Oh, 20, 30 pounds? That was 70 pounds. Yeah. What? Are you serious? It's like, yes, you can deadlift 70 pounds. You did it relatively easy. And did you have pain? And if the answer is no, I'm like, cool, we're going to do this more to strengthen these muscles. If the answer is yes, then I start critiquing their form. And it's also crazy how much when you tweak someone's form just like a little bit, usually it's like a pelvic tilt type of thing. And they're like, well, that doesn't hurt. And that felt a little bit easier. It's like, do you see how changeable this is? And then unfortunately, then it's like, okay, now I have to untie all the shit essentially that this pain doctor just told this person. And people don't understand the weight of that person's opinion and that person's statement, right? When you have a license on the wall and 90 patients in the waiting room, they think you know what you're talking about. And I mean, it's not wrong. They know their stuff, but it creates such limiting beliefs in the patient. And that's what pisses me off. And that's what makes me so frustrated because it's all of that I have to go unwork and like continuously tell them like, no, like, please disregard what they say. Like, show me your MRI, like show me your x-ray and let me talk you through what this actually means. Cause degenerative disc disease,
yeah,
man. So you're saying this is just going to keep breaking down and then they picture it, then they catastrophize it. Pain gets worse. They say, oh my gosh, I shouldn't move this. And then there you go into the spiral.
Right.
Well, wait, I want to talk about that part. It's I can't ever move this now. Because it's really interesting. So my mom has had some back injuries back surgeries. And she's like, I can't do this. She's got a whole list of things that she can't do, which includes walking. And I'm like, you can, but you can walk, you can, and you should be. Right. Well, I can't because I might fall or twist weird and I can't do any of that stuff. The lack of hope in that idea that you can't do something is profound. And
it speeds up the problem.
Yes, it does. Yes, it does. Because the lack of doing something means her muscles aren't moving and they're basically, the muscles are going down and decreasing and, so now she can't do certain things that she should have been able to do before. And so, but that's because the doctors are telling her you can't. So if you just blindly listen, conversely, there's this woman that I saw on TikTok, I think it was a while ago, and she had, and I know this isn't back, but she had a hip replacement. And she was doing yoga, like a lot of yoga. And I showed this to my mom because my mom's had knees and hips and all these things. She's like the bionic woman. That's what my kid calls her. But anyway, I said, look, I know that you're not going to be like this woman, but she's had a lot of things happen to her too and had a lot of surgeries and she still does things, but of course, looking at that model is like, I could never do that. And I'm like, I understand, but you can do something, right? Instead of nothing. And I do find this a lot in the elderly population is that once they have a surgery, they become sedentary because they're afraid of, wrecking the surgery or whatever, because they've been given the fear from the surgeon or from whoever that you can't get better or you're going to hurt yourself worse.
Yes.
And that's where the hope and the messaging that we have needs to change.
That we give as providers or that the providers as a whole.
Yeah, because Jen and I talk about this all the time, like regaining a sense of your personal agency of like change. You are the change agent. Nobody is going to change this for you. And what message are you going to start believing about yourself before you decide to engage in that change? Are you going to believe this is hopeless? Or are you going to believe that you can do something?
And what kills me with like the two stories that you guys just told was about your parents, right? I had
No, Jen, it was not Jen's.
No?
No.
Sorry, totally assumed.
We can't out that.
Huh? Okay, we'll say
He already knows. He's like,
we'll say,
I already know.
older
Just
individuals
kidding.
in our life,
Kidding.
maybe.
There you go.
Yeah.
But I
We'll go
had
with that.
an 84-year-old lady in here yesterday who trains with a personal trainer 3 times a week, does water aerobics 2 to 5 times a week, does Pilates a couple times, and I also treat her. And first of all, I said, good job, by the way, because most people your age, they just kind of quit. And you made sure not to stop moving. I said, that's the reason you're still here. This girl can still palm the floor. Like, she moves really well. But her and I kind of went on this tangent. And I said, what pisses me off so much is people your age, I think, are preyed on significantly.
Mm-hmm.
Because when an 84-year-old lady comes in and they say they have knee pain, you are someone who probably has a decent amount of money, just because you either have retirements or you have like Social Security, you have something where you've built up funds over your life. So you probably have money. You expect to be unhealthy because you're 84. Like, yeah, it's probably wearing down. I probably am not healthy, whatever. And you're very, very unfortunately, like, you just believe whatever the doctor says. And to none of this is like that person's fault. But when you start to see like this pool of people that you're like, oh, yeah, we could probably get money out of this person pretty easy. And you say like, okay, your knee's wearing down. You probably just need a total knee. They say, okay. And it's like, that's a multiple thousands, if not tens of thousands of dollars surgery. Yes. And the best part, if you look at it just from the surgeon perspective, doesn't matter how long it lasts. This person may die in 2 years, completely unrelated. Mm-hmm. Like, so you don't even have to worry about longevity. And then when they get, when they come out of it, they may have some pain. So now they're going to buy this and now they're going to buy this. And if you know anything about sales, the best way to make money is upselling, right? Like, we bought this product. What if we just tack this on? Yeah. And next thing you know, they're 2 years in and they've started, 3 different pharmaceutical medications. They're still in PT. Mm-hmm. They're still doing this. And it's just like, all right, here's the beginning of the end. And it just pisses me off because when people are in pain and they go to an ortho, they're like, okay, we can make the pain go with surgery. And it's like 50% of back surgeries aren't any better at all.
No.
And
then you find yourself in another back surgery.
Exactly.
After that. Yep. I find that if you have one back surgery, you're going to have 3 more.
Probably the next one within 2 years.
Yeah.
And it's like, cool, this didn't work. What if we do it? What if we do it again? What if we do more of it?
Okay. Right. So, all right. So as we get near the end here, I want to wrap this into something you wrote for us before the show. You said we need to get better healthcare and that it's growing, but as a patient, you need to be put first. As the client, you need to find a provider that's going to put you first. Mm-hmm. Is this part of the thing that people should be assessing when you say put you first? How does a patient know if they're being put first?
Oh, good question.
How do they know that?
One, I think it's whether or not the provider's actually listening. I'm pretty sure, I don't remember the stat, but I think it's like 17 seconds before the average primary care provider interrupts them. The average time spent with a patient in primary care is 2.7 minutes.
Yeah.
And so even if that person has a heart of gold, the provider, like when you're in a system like that, it's very hard to stay positive. Yeah. I mean, there's a reason that our clinic built a system differently. Yeah. I would say that when clients come in, they fill out their paperwork. I usually write up the questions that I'll have based on their paperwork. And then I got this from a continuing ed course. They call them asterisk signs. So signs that like the person says, I can't do this because of my pain. I can't get in and out of the car, put on my jacket, throw a ball with my kid. They have something. And it's like, cool. Every time you come in, I will ask about this because it doesn't matter what I say or what I think is getting better. If you can't feel tangible change throughout this process, then I'm not doing my job. If you're not getting closer to the goals you walked in with and are asking about, then I'm not putting you first, right? And the thing is too many times I've seen people who go to the ortho, they say, look, here's your knee, let's go and do surgery. It's like, did we even talk about this? Are there other options? Like, does my opinion matter? What if I don't want to do surgery? What are my options? And most of the time they just don't know. They say, no, this is the only option. And so that's a good question. I actually don't know how, like, I don't know a perfect way of how they know.
I think you did. I think you did. And I want to just add in there, there aren't any other options that I can do is really what that surgeon is saying that I know of. And so I don't think that that's what they say. They just say there aren't any other options, but I wish they would just say that I know of, that I'm capable of doing. Mm-hmm. I wish there was more just transparency and knowledge and more, I don't know, truth.
Yeah. Yeah, just admitting what you don't know and saying, like, here's how I help people, right? Yes. When you're a hammer, everything looks like a nail. That surgeon's probably going to suggest surgery. ultimately.
Yes.
We've heard that on this show before.
A million times.
Yes,
But it's true. It's very true.
Yes.
Yeah. So I think is there anything else that you want people to know about the power of PT that they might not know?
I would say your perceptions of PT, if they're poor, it's probably a bad PT, not a bad profession. And you need to find someone who's going to like sit with you and help you. Just like, as I know, the conversation around therapy in regards to like
Yeah.
mental therapy is, if you don't vibe with
Terrible.
the person, go find someone you vibe with.
Mm-hmm.
I mean, that's the end of it. And unfortunately, healthcare change can only come at the pace that people demand it. And so if you're not going to support a provider like me or providers like you guys, then you guys can't grow. And so it's kind of like, if you're going to advocate for better healthcare, you have to put your dollars there. You have to show up in those people's offices. And someone like myself, I don't use any healthcare dollars. Like, I go once a year to make sure like my blood's not, horrible or something. And so I don't even have power to do it because like I don't need much right now. But when you go sit with these people that you guys are talking about in those offices, like, don't give them your money. Like, don't go to that office. Like, take your bad experience and give that person a bad review appropriately. I'm not saying like destroy them, but like make sure that you're incentivizing the good providers to keep doing what they're doing. Help those providers provide so that the dollars can start coming out of the crappy system and start building up the better system. That's what I'm looking for. And that's what this podcast is probably all about as well.
Yes. Oh,
I love that idea. That is a fantastic way to put it because I agree with that 100%.
Yeah.
And by the way, most of my healthcare dollars don't go to the system either.
I know I'm having an issue because I keep firing all my doctors. So
I know.
Yeah. I'm running. I'm like, yep, we're out of that realm now because I fired pretty much everybody. So. And that's good. It's okay. Like, people fire me too. I'm like, hey, that's all right. Shop around. Like,
for sure.
Oh, all right. Well, we've reached the end of the show, everybody. Dr. Clayton Dir, rhymes with Gurr. Thank you for being on the show, Clayton. It's been great to have you.
Thank you so much for having me. This was a blast. We should do it all the time.
Every week. We'll do it every week.
We should. We'll just add
If you need a try co-host, let me know.
Oh, sure. You guys, you are listening to the Gaslit Truth Podcast. You can find us anywhere that you listen to podcasts. Please make sure that you give us a rating, only 5 stars. We had someone who gave us 4 stars very recently and told us it's because we talk too much. So guess what? Don't listen to the show. And you can find us on any of the social medias. And if you want to send us your Gaslit Truth stories, please do so at thegaslittruthpodcast@gmail.com. And that is a wrap, everybody. Thank you.